Morning, I'm Patricia, cardiologist. I'm here with Dr. Warwick Jaffe from Ascot Cardiology. Morning, Warwick.
Good morning, Patricia. How are you today?
Good, thanks. So today we're going to talk about atrial fibrillation and anticoagulation.
Yeah, I think it's traditionally we've just looked at the patient with atrial fibrillation as all the same, and we look at the CHADS-VASc score and look at the bleeding risk, and generally if the score is above a certain level, we put the patient on anticoagulants. That's pretty much how it's done at the moment, and most of you will be familiar with the CHADS-VASc score.
Right, Warwick. So tell me, are all atrial fibrillation the same, paroxysmal atrial fibrillation versus more permanent AF?
Well, I think that it's been known for a long time that the risk of paroxysmal atrial fibrillation is still significant, but possibly not quite as high as permanent atrial fibrillation. What's changed is that we can now detect atrial fibrillation much easier with the devices such as Apple Watches and also remote monitoring of pacemakers, and that's led to us finding a lot of people with a tiny little bit of atrial fibrillation just for brief periods of time, and there's been now a lot of studies done on these sorts of people.
So what do these studies show, Warwick?
Well, what they really show is that the risk in people who are having brief episodes of atrial fibrillation, the risk of stroke in general is much less than people who are having longer periods of atrial fibrillation. So the concept is now we need to look at the length of time a person's having atrial fibrillation for, and also how often they're having that atrial fibrillation for, and come up with some sort of idea of the atrial fibrillation burden. And so I think patients who are at have a low burden will be people who spend perhaps less than 5% of their time in atrial fibrillation, or people who have attacks that are less than a few hours long. And certainly people that have attacks for a matter of seconds have got a very low sort of AF burden, and we now know a lot more about those sorts of people.
What does that mean in clinical practice?
Well, in clinical practice, we've previously looked at people as either having atrial fibrillation or not having it. So it's a binary thing. You've either got it or you haven't got it. If you've got it, you get put on anticoagulation according to the CHADS-VASc score. We now also need to look at the burden of atrial fibrillation and combine those two things to come up with an idea of who should be treated. So, for example, a person who's got a low CHADS-VASc score or a borderline low one who's got a low burden of atrial fibrillation, but brief atrial fibrillation, they probably wouldn't be put on anticoagulants now, whereas previously they might have been. And the opposite's also true. Let's say you've got a patient who's had a stroke or something like that, but no obvious cause has been found for it, and then they get a brief episode of fibrillation found in some manner. You might think, my God, well, that person's had a stroke, so we would put that person on anticoagulation because we've now got a little bit of evidence of atrial fibrillation.
Can I give you a hypothetical scenario, Warwick?
You can.
If there's a middle-aged man that wants to take up on regular exercise and he's bought an expensive iWatch, which showed him he's got atrial fibrillation, what would you do?
Well, first thing you do is look at his Apple Watch, because these things do print out the ECGs, and if you're absolutely certain that it's atrial fibrillation, that's a bit of a problem for you. You could try and work out how many times he's had it on his watch, because those watches do keep track of that. But in general, if they're a pretty healthy person and you'd do their CHADS-VASc score, and if the CHADS-VASc score is 0, you might think, oh well, they're at low risk, we'll just won't give them anything at the moment, but we'll send them for some more prolonged monitoring, for example with Holter monitoring or something like that, or for cardiology referral. And if that was pretty low, then you might leave that person off all anticoagulants.
Right.
So it becomes more difficult though if the person's at slightly higher risk, and if they're at slightly higher risk, the safe thing to do in that person is to put them on an oral anticoagulant and then do a cardiology referral, understanding that with our current COVID restrictions at the public hospital, it's going to take a very long time to get that patient seen. But I think the safe thing to do is, if you're not sure, it's pretty safe to put people on oral anticoagulants temporarily.
Right, in summary, basically the approach to patients with very low AF burden versus with high AF burden, their risk for stroke are not exactly the same. And we probably will often start with a conservative approach and suggest they be put on anticoagulation until full comprehensive assessment of their risk is done, then have a management plan for these people in terms of long-term plan for anticoagulation.
Yeah, I think that's correct, and I think the biggest thing you can do as a general practitioner is if you face this patient who's got this Apple Watch or something else saying AF and they're panicking, you should say, well, look, just don't panic. It's quite common for people to have little bits of it. It's often not very dangerous. We're going to keep you safe if they're at high risk by putting you on oral anticoagulants first, send you for cardiology review. And I think if they're at very low risk of stroke, then you don't need to do anything except reassure them and say, well, we'll find a bit more about this with more monitoring of your heart.
All right. Thank you, Warwick.
Okay.